Great. Thank you. Thank you, Jeremy. And I presume everyone's hearing me. So let's move on. So I want to talk a bit about 3 decades of HIV in Southern Africa and in South Africa in particular, and ask the question, what have I learned? What have we learned as a community of doctors and nurses and people who have an interest in caring for the sick? What have we learned? So let me start with Sir Michael Marmot. Um, the unnecessary disease and suffering of the disadvantaged, whether in poor countries or rich, is uh, a sign of a way we organize our affairs in society. And I'm just going to move so there we go. Great. Um, Now I need to move forward. Um, so let's see if we can do that. That's not doing anything there. Okay. Okay, there we go. Great, thanks so much. So 3 decades of art and declarations. Hey, I've got no financial declarations to make, and the content is data relevant to our South African situation. Let me quote again from Sir Michael Marmot. The differential status of men and women in almost every society is perhaps most pervasive and entrenched. Indeed, the feminization of the AIDS epidemic, and this is Sir Michael writing back in 2007. Indeed, the feminization of the AIDS epidemic in Southern Africa clearly indicates the lack of power of women to participate as equals in the social freedoms of men. But what have we learned? Well, let's start with this issue of teenage pregnancy in South Africa. And this is from the News 24, almost 120,000 girls aged 15 to 19 years have given birth in South Africa in the last 12 months. And they go on to give us a number of young girls and teenagers having babies remains constant in South Africa, with more than 2,200 girls aged 10 to 14 years giving birth at public health care facilities during the 23-24 financial year. News 24 reports that KZN has the most, and in the same period, 120,000 girls aged between 15 and 19 gave birth in the same facilities. So we kind of have a problem. If we look at the Statistician General's report from over the period 2018 to 2024, if you look at the graph in front of us, you'll see that on the left-hand side, the total group 14 to 19 is displayed, and then we have on the x-axis the particular years, the 14 years, 15, 16, 17, 18, 19. And you can see very clearly that over the period of time, 2018 to 2022, there hasn't been a huge amount of difference. But still a large number of young females, girls, teenagers falling pregnant. That means clearly something about HIV, because where there is pregnancy, there is obviously sex. And if we look here at the 6th South African National HIV Prevalence Survey, in front of us, the incidence of people living with HIV in South Africa, 2017, we had 7.9 million, 2022, 7.8 million. So it's kind of remained constant, largely constant. Prevalence overall 8% in the Western Cape, but 22% in KZN. So already we are seeing there's a pattern to the HIV prevalence in our country. Viral suppression generally kind of not fantastic, but 83% in females, 79% in males, but the younger group, 15 to 24, 70%, 25 to 34 in males, is only 66%. And in the little box that I've given you, Lee Johnson and Rob Dorrington's data from April 23, 11.2%, and that's the prevalence in the 15 to 49-year age group in the Western Province, and 24 to 9% prevalence in KZN. If we look at women and men, what is obvious in the graph in front of you, and again, it's from the KwaZulu-Natal, and particularly from the Edendale area of KwaZulu-Natal, women in particular, girls in particular, are at risk of being HIV positive. When we look at the countries around South Africa, Eswatini, Lesotho, Malawi, Zambia, Zimbabwe, you'll see on this graph, females, 10 to 14 females, 15 to 19, and then on the right-hand side, their male counterparts. You'll see that the prevalence of HIV, 2.5%, 3% by and large, but it's always Eswatini, and it's Lesotho particularly that have a problem around us. So the countries around South Africa share our problem with HIV. In terms of the prevalence of a viral load below 1,000, which is the WHO kind of cutoff in terms of treatment and management, again, looking at that same age group, females on the left, males on the right, by and large, about 75% of patients are young females, young males, are able to control the viral load at below 100, below 1,000, whereas as they get older, 15 to 19, that drops to around about 50%. HIV transmission. So I want to share this particular paper. And when I was looking at the question of 3 decades of antiretroviral therapy, I also thought that I would share with you some of the papers, the scientific papers that I felt were really important and helpful in terms of clarifying where we are and where the epidemic is going. So this is a paper from 2017, Tulio D'Oliveira, when he was still in KZN, and a very significant paper looking at sexual partnering between adolescent girls or young women and older men, and showing that the key feature of this is sexual networking, which is driving this transmission of HIV. And this graph in front of you clearly describes the HIV prevalence on the y-axis, the age, and the on the x-axis, and you'll see that the prevalence of HIV in women occurs or reaches a pinnacle in the age group 30 to 34, and that's about 10 years younger than the men. The men reach their peak at around about 40 to 44, and the cycle of transmission that Tulio mentions, the cycle of HIV transmission is driven by high rates of HIV acquisition in adolescent girls and young women, 15 to 25 years of age, principally from men who are already in their 30s. And hence this diagram of young women below the age of 25, young women between the ages of 25 and 40, being the individuals who are an essential component of this particular networking system. And in addition to showing us that there's this networking, Julia has also phylogenetically identified a large number of these viruses to show that if one goes to Farmashu in Durban or other parts of KZN, and then you look at the rural area, you can find identical variants of the clade C HIV virus in those areas. In other words, making it very clear that there is transmission between the rural areas and also the towns and the cities of that province. Here we look at another important paper looking at HIV incidence, all-cause HIV positive mortality, mortality ratio, incidence mortality ratio, and HIV prevalence, again in KwaZulu-Natal, showing that over the years from 2005 to 2017, there have been changes, and those changes reflect the antiretroviral therapy that has come into play. And but the HIV prevalence, as you see there, and we're looking at the dots, which are women, and the triangles, which are men, and you can see very clearly that the prevalence is slowly increasing, as you would expect, as antiretroviral therapy prolongs survival in those areas. Lenacapavir. So this is a new drug known as a nucleoside translocation inhibitor, NRTTI, and it's a drug that I want to mention because in a moment I will want to kind of bring your attention to the report in PrEP, where our colleagues have been using lenacapavir as a preventive, and particularly in the group of young people that I've been talking about in the last 5-10 minutes, lenacapavir, I believe, could be of great use. So you're seeing here from the from Michael Sark's picture and David Spark's picture of this, that it has two places. This is a capsid inhibitor, and both at nuclear transport of the capsid of the virus into the nucleus, there's inhibition, and then also at the release, at the release of the capsid, there is a problem. The virus is blocked. Their dosing schedule, so we have oral and we have also subcutaneous forms of lenacapavir. So let's go through to this particular Linda Gale Becker's recent publication in the NEJM of the twice yearly lenacapavir study. And if you look at the right-hand side, the randomized cohort, one group got subcut lenacapavir twice a year, every 26 weeks, with either oral M-tricytamine, FTC, and TAF, tenofovir alafenamide, or oral M-tricytamine, and with tenofovir diazoproxil fumarate once a day. And the latter two were given as a placebo. So this is a group who were on the lenacapavir alone. And then there were two other groups, one with oral TAF regimen with M-tricytamine and oral tenofovir diazoproxil fumarate. The outcome of that, as I'm sure you're familiar with, it was 5,338 participants. The incident infections over a period of 2 years was 55 of these young people, young women, were infected, but none in the lenacapavir arm. In the TAF arm, 39, 16, and the diazoproxil fumarate arm, and very clear evidence that lenacapavir significantly lowered than background HIV incidence in the cohort as a whole. Conclusions: no participant receiving twice yearly lenacapavir acquired HIV. HIV incidence with lenacapavir significantly lower than background incidence of acquisition with tenofovir and emtricitabine. Again, you've got these bar diagrams in front of us showing the lenacapavir on the left-hand side, incidence of HIV 0. And on the right-hand side, looking at the incidence rates, again, lenacapavir shows evidence of no transmission and of excellent outcomes in this group. So if we were to go back to the story of our young people, our young girls falling pregnant and the risk of picking up HIV, then surely we need to be thinking in terms of this long-term strategy, which I have no doubt Linda Gale, Brock Becker, and others in the government are probably also looking at a strategy of introducing this in South Africa. If we look at the origins now of HIV in Africa, and this is a paper from a few years ago, 2014, and Nuno Faria. Just to remind you, and on the right-hand side, you're looking at a map of Cameroon, Gabon, and of the Democratic Republic of the Congo. Remind you that the origin of HIV, somewhere in the 1880s to 1916, i.e. 100 years ago, we believe that the virus was transmitted, brought down from the Cameroons, and you're seeing the Shango River here, coming up here, and in this area we have a troop of chimpanzees who we believe gave us the ancestor virus, the ancestor lentivirus that now is the grandfather origin of HIV. And if we look at this particular famous paper report, June the 5th, 1981, that was the report of pneumocystis pneumonia in 2 young men, both of whom were gay, and who were later found to be HIV positive. So the beginning of the HIV epidemic, although indeed it must have begun probably 100 years ago, but unknown to the world as such, but the current epidemic that we are aware of kind of begins in its roots in 1981. And here I put a report in of our situation in South Africa, and you'll remember, many of you who are listening to me, that there was trouble. This is Lancet 2008, a world report that within hours of taking office on September the 25th of 2008, South Africa's new president, Kgalama Motlanthe, signaled clear break from President Thabo Mbeki and the then Health Minister, Mantashabalala Msimang, and that this decade that we had been through, where we had trouble with HIV denialism and the inability to get hold of drugs, was over. As mentioned by Francois Spencer at that particular time. I want to talk about HIV and the life cycle, remind you of the picture of the virus, it's a retrovirus, and as you see on the left-hand side, in this electron micrograph, it is there is an inner capsid that kind of bullet-shaped nucleus or capsid, and around that an enveloped virus with spikes. And in the artist drawing, you can see very clearly on the right-hand side, two RNA strands surrounded by a number of enzymes that the virus uses in its division and in its growth cycle. Just to remind you, from that period, 1983, 1984, that the virus on your left-hand side in this photograph of Luc Montagnier and Francois Boré-Senoussi in the Pasteur Institute in France. But these were the two folk who were given a Nobel Prize in 2008 for discovering in that particular lymph node biopsy the virus. That allowed us in '84 to develop blood tests and then move on to managing HIV and its infection. Here's the life cycle, as I'm sure many of you are familiar with, and I want to, in a moment, to talk about these two new drugs. I've spoken about the capsid inhibitors and lenacapavir, but on the left-hand side, I want to, in a moment, talk about islatravir, which is a nucleoside reverse transcriptase translocator inhibitor. Let's look at those drugs, and you're familiar with this particular picture, that we have drugs now that effectively halt the virus's entry into the CD4 cell, and then its division within the cell. NRTIs and NRTIs, integrase inhibitors, protease inhibitors, and, as I say, these capsid assembly inhibitors. This is, again, from the Americans, a recent notification of all of the new drugs that are available. And as you look at this page in front of you, you'll see that integrase inhibitors, non-nucleosides, bNAbs, these are antibodies and co-formulation capsid inhibitors, and these nucleoside reverse transcriptase translocator inhibitors. A large number of drugs are in the pipeline in the future, hopefully reassuring us that the future is not entirely bland, that we have got an armamentarium for the future. I put in this slide, I listened to these virology lectures with Vincent Raccanello from the United States on a weekly basis. And this picture is a reminder to me of the busyness of the cell, that when the viruses get into cells, they have pathways, furin pathways that you're looking up on your left-hand side, and pathways that allow entry, in the case of HIV, into the nucleus of the host cell. I recall that in the early days, when I'd come back from America doing my fellowship in the United States, we were using, and I was using AZT in patients in Cleveland, but seeing very little response. So this particular paper was an amazing and helpful paper, because Edward Connor described it, and I was in Prague in April of 1994, when he showed this graph to us of using AZT to prevent infections in pregnancy, i.e. infections of the baby. So this was a form of PrEP, but protection of the unborn infant. And this is really post-pregnancy, and then looking into and the effect of zidovudine versus a placebo, and a significant decrease of more than 12% reduction in the level of infection within infants who were who had HIV transmission from their mothers. So at that particular moment in 1994, we understood that the antiretrovirals, and particularly this was AZT and nucleoside reverse transcriptase, were effective. We needed to get, however, a body of drugs, and in this particular paper from a few years later, 10 years later, Roy Gillick, triple nucleoside regimens, showing that really there wasn't in these Kaplan-Meier graphs, there wasn't sufficient improvement. So when we used, in this case, 3 NRTIs, the virus was not eliminated. So it was the beginning of our learning that there was resistance was going to be an issue that we would have to deal with. Prevention of HIV, clearly an important issue. This is a paper from Mike Cohen, and I think many of us here who've worked with Mike Cohen and who worked on the HPTN 052 study will be aware of these early studies. And I'm looking particularly at 052, and this was in the cohort immediate antiretroviral therapy or delayed antiretroviral therapy, waiting until the CD4 count was of these discordant couples, 1,763 to 0 discordant couples, one positive, the other negative. If we waited for that CD4 count to drop to a level below 350, maybe 550, and only start then, we saw very clearly that the result was that groups of patients became of the partners became infected. In fact, only one infection occurred among those couples starting antiretroviral therapy immediately and not waiting until the CD4 count dropped. And this showed a 96% reduction in transmission. Sexual activity without condom and risk of HIV transmission was a paper that followed this by several years later. But what was shown here is that even without condoms, by giving antiretroviral therapy in different heterosexual and MSM couples, in which for one partner was positive and was using suppressive antiviral therapy and reported condomless sex. During the median follow-up of 1.3 years per couple, there were no documented cases within those couples of HIV transmission. And you're seeing very clearly from the graph in front of us that it's at every level, whatever sex the couple were involved in, vaginal sex without ejaculation, anal sex, receptive anal, and so on. Whatever it was protected, provided we had the virus under control. And it was studies like this that informed our understanding of undetectable viral loads, meaning untransmittable virus. So a very pivotal moment in the understanding of what antiretroviral therapy could do and what our antiretrovirals were capable of. I'm going back to looking at South Africa and the risk of acquisition in rural KwaZulu-Natal. Frank Tanzer and Till Bartley-Housen's paper, well-known paper, back from Science in 2013. a landmark HIV prevention trials network 052 trial in discordant couples that had shown us that the drugs work and work very well and effectively. And these group of researchers used data from their large population-based cohort study in rural KZN and looked at other key factors, individual acquisition rate declining, so that here we see our researchers looking at time series maps showing the population in rural KZN, Matuba and townships of that sort, as you look at the graph above A and then graph below B, and one seeing the numbers, those receiving art, and you can see in top graph that over time, from 10%, researchers point out they are surviving over the long period. So insights start study looking, so when should we be starting antiviral therapy? So there were two pivotal significant trials, the INSIGHT trial, and also, and we'll come to that, the studies done in West Africa. This was a study done in Europe, Africa, and South America, where HIV positive antiretroviral naive adults with CD4 counts greater than 500 were randomized either to start antiviral therapy immediately, that was more than 2,000 of them, or to defer ART and to wait until the CD4 count was below 350, which was kind of at that particular time, we look at 2015, the norm in our areas. So I can't move it forward. Thanks. Thanks. So start study with the introduction of immediate ART, as you're seeing from its Kaplan-Meier graph, on the x-axis the months on treatment, on the y-axis the cumulative percent of those with various events suggesting serious AIDS or non-AIDS related events or death. A significant decrease, 57% decrease in serious events in those in this particular trial. And again, there were differences clearly important in terms of all of these factors on the left-hand side were impacted, and the subgroups that defined this HIV RNA levels, risk of coronary artery disease, these were all things that were looked at that particular time, and there was evidence that in many instances there was improvement, as you see in the Framingham 10-year cardiovascular, smokers, differences there. The PRANA study, the START study, as I say, done internationally, Temprano done in the Ivory Coast. Similar study looking at, well, when should we start antiviral therapy? Immediately, and you're seeing two groups there, one with antiviral therapy alone, the other with RPT, isolated preventive therapy, and then the deferred group. And we're looking at around about 2056 people in all of this in this study. And again, similar to the START study, you're seeing that immediate art, with or without IPT, is far better than deferred art in terms of cumulative probability of death or severe HIV-related illness. And again, on this particular Arbor graph, you can see that all of the factors that were looked at, there was significant improvement in those in the early group as opposed to the delayed group. These were significant studies that determined how we should be managing our antiretroviral therapy. In South Africa, and I presume elsewhere in the world, we had, over that period of time when we had antiretroviral therapy, we had, excuse me, while I take some water. We had divided the groups into first line, those who were ART naive, second line, those who failed first line, and third line therapy. And coming up from that, the resistance challenge, and then I put at the bottom, what is the future of all of this? Is there a cure? So again, going back to trends in pre-treatment drug resistance, this is from the group in Durban, just looking at pooled analysis of and what we're looking at is that there is an increasing pre-treatment HIV drug resistance, particularly since the acceleration of ART in 2010. Increase is driven particularly by the NNRTIs, but levels of NRTIs are also rising, resistance to the NRTIs. And we note an increase of tenofovir resistance mutations. And in the study, the implications of their findings clear signal that that pre-drug resistance in South Africa has reached a threshold at which WHO recommends urgent public health action, particularly because the NNRTI pre-drug resistance is over 10%. Our data supports the decision to move to a dolutegravir-based first-line regimen, but underlines a greater need for improved treatment supervision if South Africa is to end AIDS by 2030. And these were the graphs that they showed, kind of bubble-shaped bubble graphs, prevalence of pre-treatment HIV drug resistance by year of sampling. You're seeing 2000 up to 2015, and you're seeing the overall in graph A, B and C and D. These are NNRTIs, NRTIs, and PIs. Relatively little happening in the PIs in terms of resistance over this 10 to 15-year period, but definitely an increase in resistance in the NNRTIs and a slight increase in the NRTIs, as this Durban group has shown. At the same time, we were also dealing with drug toxicity. And I'm sure many of you who have managed patients are familiar with these sort of pictures. Drug toxicity here, lipoatrophy, particularly of the face, lipodystrophy, and gynecomastia in men on efavirenz, in particular also stabiline, didanosine, lipodystrophy, buffalo humps in patients, and toxicity itself with the NNRTIs, particularly nevirapine, but also to some extent efavirenz. But and a pretty desperate patient. This particular lady discussed with me many years ago, who passed away, who died as a result of toxic epidermal necrolysis, TN, as a result of efavirenz that she was being given. And then the question also of chronic heart disease, of ischemic heart disease on the increase. And certainly in the earlier days, we had a belief that over time, increases were of heart disease were a problem. The advanced study you'll be familiar with again, investigators here in Johannesburg in South Africa, looking at dolutegravir, TAF, FTC, dolutegravir, tenofovir, disoproxil fumarate, dolutegravir, and what was the regimen of that time, that period? And we're looking at a couple of years ago, 2019, a few years ago, 2019, efavirenz as our tenofovir, emtricitabine, and efavirenz. And the issue that really surfaced and has remained an issue since, weight gain generally occurring within the first year following initiation of the ART, greater weight gain associated with INSTI or TAF compared to efavirenz, PI, and tenofovir, but the switch from INSTIs and or to the INSTIs with or without TAF, and it's more likely in women, Black women, Hispanic women in particular, and use of efavirenz, tenofovir associated as such with weight suppression. And INSTIs may be associated with incident cardiovascular disease, diabetes, hyperglycemia, hypertension, and so on. Conditions of chronic HIV infection. Again, this is Mike Sarg commenting a year or two ago, 2020, on the initiation of ART leading to weight gain and these other factors which we've just been talking about a moment ago. And the metabolic complications and the treatment, counseling, patients documenting weight gain, BMI, baseline every 6 months, and yearly screening for diabetes, cardiovascular disease, if on an INSTI, and lifestyle changes, and if the weight gain is more than 5%, until there are data providing proving benefit, switching of the ART because of weight gain is not recommended. And these are the American guidelines at the moment. Islatravir. So I said I would mention islatravir, and this is a new potent, long-acting antiretroviral, a nucleoside reverse transcriptase translocator inhibitor. And what we know about this is that it acts and behaves as a nucleoside reverse transcriptase inhibitor does, but also, so as you're seeing, it prevents the nucleotide binding and the incorporation of this into the DNA chain. So with reverse transcription that is occurring, it blocks, so it's a chain inhibitor. But then there's delayed chain termination, which prevents the nucleotide incorporation even in the event of translocation. So even in the event that the islatravir is incorporated, then there's still a blockage of further nucleotides getting into the particular sequence, the DNA sequence. So a very interesting molecule. And as you look at the activity against wild and resistance, NLTI resistance, down on the islatravir on the graph on the left, as you know, on the table on the left, rather, you'll see that in fact the IC50 is really very low, to even in the face of multiple resistant mutations, as you're noticing there. So the ability of this, and as you see also, if I go back there quickly, that with these very low IC50s, that a very small dose of islatravir is very potent. A novel mechanism, potent high barrier to resistance, as you've just seen, a long intracellular half-life, 120 hours in healthy volunteers. So that has implications, just as with lenacapavir, the capsid inhibitor. So with islatravir, this translocation inhibitor, NRTTI, a long intracellular half-life means that there's flexible dosing, novel delivery, and we already, in fact, have different ways of administering this particular drug. Here, for instance, an implant and giving the drug uh, uh, every year, once a year, 6 monthly, and so on. So we have, like with lenacapavir, drugs or drug that can be given less frequently in combination. You're seeing here combination with doravirine already is being tried, and may have, again, like lenacapavir, with prolonged activity, it may have potential for PrEP as well. These are some of the drugs that we have. I'm not going to spend time, you're familiar with that, but let me just remind you of where we are in terms of the United States and South Africa in terms of antiretroviral therapy. So the integrase inhibitors that are in first-line therapy in the United States, bictegravir, dolutegravir in particular, as you're seeing there in this particular report from 2018. Comment from Melanie Thompson in her review 2024, again from the Americans, Raj Gandhi and Melanie. There's much less interest now in daily drugs and antiviral therapy. The new strategy is either weekly or maybe even longer, with long-acting injectables, aiming for 3-month dosing intervals, maybe longer, subcut, less feasible as the volume increases. BNAbs, and looking for their niche, so they haven't found that yet. Lots of promising compounds in the pipeline for 2025 and beyond. Cost will be a challenge, certainly for us in Africa. Equity of access should be prioritized. Prof. Thompson comments. This was from our 2020 Southern African HIV Clinician Society guidelines, showing again that our drug, our stable drug is dolutegravir, tenofovir, M-tricytamine, 3-TC or FTC, and dolutegravir. And together with that, there are some alternatives that we're familiar with at the moment. So I kind of want to say one or two further things. We're nearing the end of the discussion, and I don't know whether there are any comments in the chat box. But before I do, just to talk a bit about resistance, the EARNEST trial. You'll remember Nick Payton, 2013, first-line NNRTI failure. So we're looking then at second-line therapy in first-line failure. And you'll remember, I'm sure most of you remember, the definition of good disease control, the PIs in orange, PI and NRTI in gray, the PI and raltegravir, integrase inhibitor, and then monotherapy. Clearly, monotherapy is not appropriate, and that was with lopinavir, and that has passed its duration of use. But what for me was interesting with this particular trial was with resistance, that we still, in fact, had some potency of the regimens. And that has been a feature of the larger trials, the first and the second updated larger trials as well. And looking at these particular trials, dolutegravir-doranavir combination, they were of equal value, but zolpidem particularly more resistance and a weaker control with the AZP, with zolpidem in terms of therapy. So that's where I kind of wanted to end our discussion and ask, where's it going? Where's it taking us? For myself, as an HIV clinician with some 3+ decades behind me and no longer in the field, the question I'd really want to ask is, can we get to 2030 with a realistic possibility of no further transmission of HIV on the one hand, and I don't know about a cure. I think a cure is still kind of in the future. But can we prevent the transmission and get no new cases of HIV? When I look at the Australian data, the American data, and some parts of Europe, they are in fact managing to bring this virus under control and decrease and prevent new infections. Are we going to be able to do that in South Africa, in Africa, in the countries around us, in the rest of Southern Africa? I'm not sure. Good. Thank you very much, guys. I hope that was helpful.
Thanks so much, Dave. Really, really nice overview of the key, the key trials and developments over 30 years. It's been quite a ride, I think, Sydney, for people like you who've seen it really from the beginning, in South Africa at least, and onwards. I guess, yeah, I mean, you ask about how to prevent infections going. I mean, I suppose that's one of the most exciting things is this lenacapavir study with Linda Becker, which really is, to give something twice a year and prevent infections almost flawlessly. And I think that's got to help with, that's got to be the next frontier in terms of activism, is to get this drug as soon as possible. We know PrEP has always been useful when taken, but it's always been very difficult to take, and people haven't managed to keep the adherence levels up. And so, to allow people to come in twice a year for injections is a real sort of game changer, I think.
So what, Jeremy, do you think, what can we do, particularly for KwaZulu-Natal? I mean, is there, when I looked at youngsters who are young girls who are pregnant, it looks as though, would you prioritize KZN, and how would you go about that? What should we be doing for health?
Yeah, Sydney, probably the country's hotspot, so it's got to be the focus there. But I think there's so many steps in terms of the implementation which has to be thought through. I mean, the price is the biggest one. It does seem like it's in theory possible to get the price reasonably low for low and middle income countries, not at the price it's been charged now, but intrinsically, in other words, it's not intrinsically a very expensive drug to make, at least when given twice a year. But there's, that would entail a very different sort of set of programs that the HIV Directorate and the country would have to roll out. But I mean, none of that should be a barrier. It's just something we have to think about, and we have to do it quickly because, as you said, we're still getting over 100,000 new infections a year, and in this country, and it's all of these now, as of June, when the lenacapavir study was published, all of these now we know to be entirely preventable.
So, in terms of our weakness, I think, Jeremy, in many ways has been the development of resistance. And at the moment, it looks as though both islatravir and also lenacapavir kind of will eventually fade. Not at the moment. They're new kids on the block. They are very potent, and very little evidence of resistance emerging. What do you think? Do you think that we will eventually lose these? And would that be an important event, or an important thing to be looking out for?
Well, one thing you taught me was about, because you've done this, been around the block a few times with the resistance issue, is that whenever anyone promises you a new drug which won't get resistance, it's certainly a chimera. It'll happen. But equally, though, it's certainly true that we have much more robust drugs in terms of resistance than we did 10 years ago, and certainly 20 years ago. So it's certainly less of an issue. But the biggest way to prevent resistance, in the same way as with antimicrobial resistance and antibiotics, is not to get the infection in the first place. So I think as much as we're able to prevent infections, I mean, that's a huge part of preserving these drugs down the line. I'm just looking at some of the questions in the chat. I'm actually going to, Nasisa, if you're able to unmute, perhaps that you could take it. Mohammed Nazir is asking, what's the suggestion on management of newborn from serodiscordant couples, particularly when the mother's seronegative, with regard to ARV prophylaxis?
Thanks, Jeremy. So I think the starting point, I take it then the partner, the male partner is the one that is positive, is that the male partner should be on ARVs and virally suppressed, because then, undetectable will be untransmissible to the mother. But it may be a situation that she doesn't have much control over. Then the second aspect is that, on top of all of that, she should be using a barrier contraception, which as well may not be something that she fully has control over. So then the third layer of protection would be to use PrEP for that serodiscordant mom who would be either breastfeeding or that sort of thing. And then how the duration of that risk would be related to whether she's breastfeeding or not. And of course, we do encourage breastfeeding for its many, many, many benefits. And so that's what I would advise, and definitely a PrEP for her as well, and something that would be completely within her control, the PrEP specifically.
Oh, thank you. I know we've just gone past 4, but I'm just going to take the last 2 questions in the chat very briefly. You asked, Nasisa, and thank you, sorry, for those who are aware, Nasisa runs the HIV clinic at Krisani Baragwanath Hospital, the pediatric side, and is very, very experienced, so we're very lucky to have her. And she was asking about the implementation plan for long-acting drugs as well for prevention and treatment. So, I mean, I think there's 2 challenges for treatment. That's been a bit disappointing in terms of the access locally and the sort of willingness to roll it out from some of the companies. I think the treatment is a very long way away, unfortunately, still. In terms of prevention, with something, like cabotegravir, for example, specifically, obviously, that's really just a question of price. At the moment, it's too costly for the Department of Health, as they've done their own assessments, as I understand it, at least. But there's no question of efficacy or willingness. Obviously, where that fits in with lenacapavir, obviously, is another whole story. But I think that's, as far as I know, at least, I'm not the one making those calls, but that's where we are. And then very lastly, Halima Dawood from KZN is asking, perhaps to Dr. Spencer, should we be using the same drugs for treatment and prevention, I guess, given the potential for resistance?
I mean, I think that's a really interesting question that I haven't thought through, but just kind of thinking through it right now. I mean, if we've got sufficient new drugs, it would be quite a useful plan to park them and particularly use them, as you say, not so much for treatment, but for prevention. And yeah, I think that's a very good idea. To be honest, I don't know if you have any ideas, Jeremy.
No, I mean, I think that's wonderful. I mean, like you said, so I mean, that's another huge advantage of the lenacapavir, if it ever does get rolled out, is it's really a different class from any of the drugs you use as therapy. It's not a big problem. I don't think that should prevent the prevention from going ahead. I mean, we know with cabotegravir, sometimes if you do get a breakthrough infection, that resistance can cross-react with the dolutegravir of your first line, but it's pretty uncommon. And I think the benefit of using them in the first place, I think, outweighs the small risk of resistance. But it is something to consider always, and I think it's a great thing to keep an eye on. Thank you very much. Just to thank you again from our side. There's comments. The chat is full of comments thanking you. So really, really wonderful presentation, and it's such a wonderful thing to have you giving us this perspective. And I think we've all learned something. It's a really nice overview of 30 years of quite cutting edge medicine.